Good afternoon and welcome. My name is Nare Parad. I'm the Director of Research and Director of Health Economics and Evaluations Research at the UCLA Center for Health Policy Research. It is my pleasure to welcome you once again to our 2015 Health Policy Seminar Series and to today's discussion of, if the number of the media calls that we get on this topic is any indication of how important it is, a topic of great concern to many, the so-called narrow networks. What is a network? Simply put, it is a term that describes a health plan that contracts with a limited number of doctors and hospitals to provide health services. Many health insurers offering plans through the ACA Exchanges in 2014 and 2015 had these so-called narrow networks. A smaller number of hospitals and physicians in the list of providers that are on these networks, leading patients to worry that they might be restricted from using the doctor of their choice, and this might have a negative impact on their health. Today's seminar will try to demystify the truth and reality of narrow networks and is presented by one of the nation's leading experts on health insurance and health economics, Dr. Gerald Kaminsky. So just a glimpse of the next month's presentation and the webinar. It's going to be called Why Don't More Community Clinics Provide On-Site Dental Care? It's going to be on November 19th. Dr. James Crowell, Professor and Chair of the Public Health and Community Dentistry Division at UCLA School of Dentistry, and myself will discuss a recently released study on the availability and access to dental care in California's community clinics. In this study, we found that only 3 in 5 community clinics, community health centers, had dental care on site, and that patients were forced to travel 5 miles or more to get dental care at more than 100 community clinics statewide. We will also make the case that grouping primary and dental care under one roof can benefit both patients and a clinic's bottom line. As for today's seminar, it will be placed on our website at the address that you see here on the slide. In terms of the Center's ongoing health policy seminar series, you can find the links to all our past and upcoming seminars on our website and by subscribing to our monthly e-newsletter, Health Policy News. If you'd like copies of today's presentation, the slides can be emailed to you. Please send an email to our Communications Director, Gwen Driscoll, at ucla.edu. You see her email address here. Please note that we'll be taking a break in the month of December, but we will be resuming our seminar series in January of 2016. Please also note that we will have a brief question and answer period at the end of today's seminar, and I'll moderate that. I'm now happy to introduce the presenter of today's seminar and the director of the UCLA Center for Health Policy Research, Dr. Gerald Kaminsky. Dr. Kaminsky is a professor of health policy and management at the UCLA Fielding School of Public Health. He's also the editor of a book, Changing the U.S. Healthcare System, Key Issues in Health Services Policy and Management, now in its 4th edition, and a comprehensive single-source account of the major health policy and management issues facing the United States. A health economist and policy analyst by training, Dr. Kaminsky is responsible for the Center's strong focus on the cost and cost-effectiveness of healthcare programs and technologies, with a special emphasis on public insurance programs. He is the co-developer of the California Simulation of Insurance Markets, CalSIM, predictive model, which is helping the state forecast eligibility and enrollment under the ACA. Dr. Kaminsky also helped found the cost impact analysis team of the California Health Benefits Review Program, CHIPR, which conducts legislative analysis for the California legislature of proposals to expand mandated insurance benefits. Dr. Kaminsky is one of the elite club of lucky health experts to have read almost all of the 1,000 pages of the ACA, as well as many pages of the regulation associated with the law. He's infinitely familiar with how health plans are adapting to the law. Please welcome Dr. Gerald Kaminsky.
Thank you, Nadi, and it's a pleasure to be here today to talk about this topic. Like many things related to the ACA, one of the things I'd like to do today is sort of, to use current terminology, unpack some of the issues surrounding narrow networks, because there are sort of factual and sort of what I would call legitimate concerns, and then there are political concerns that have been raised about narrow networks, and I'd like to try and separate the two. As somebody who works on policy issues related to the ACA, and somebody who's spent his career working on policy issues and doing academic-based research on those policy issues, it's important, I think, to step back and try and look at what some of the underlying issues are from both a research and a policy perspective, and that's what I'd like to do today. So let me start by just setting the background. Why are we concerned about narrow networks? Where does this concern come from? And it's clearly related to the ACA. Now this slide, this is in a sense where it all originates from right now. This is the Covered California website. This is a recent snapshot, and actually, you know, they've made changes to the website recently. The way that it looks right now is a little more difficult to navigate and understand. I'm not exactly sure why they updated it this way. A few months ago, it seemed a little more clearly laid out. But that point aside, what I want to do is emphasize that this is the marketplace. This is what the ACA created. This is a marketplace where, starting next week, Californians are going to go to shop for health insurance if they don't have insurance through their place of employment. This is where they'll find out whether or not they qualify for subsidies and purchase qualified health insurance plans that were created as a result of the ACA. So this is the shopping. This is the marketplace. And the fact is that we really, just to remind everybody, we did not need the ACA to create marketplaces. It's perfectly conceivable, and in fact, a number of private vendors have set up their own private insurance marketplaces that look like this. But the website is really where the comparisons break down. In other words, private insurance or private marketplaces or exchanges may have websites that look like this and offer products, but let's get into the heart of why the ACA is different from those other websites. So this is a snapshot of just some of the policies that are available right now in what will be the current open enrollment season. And what I want to emphasize here is that you get information about what plans are available in your market area based on your income. You get specific information about the premium of the plan and after financial assistance, as well as with what it would be before you get that financial assistance. The other thing that Covered California has done, which I particularly like, and I want to see more information on this in the future, is the line that shows your expected out-of-pocket payment for these plans. So we've got the total cost, which includes the cost of the premium, but also the expected out-of-pocket spending associated with each of these plans. What I haven't shown you here is that in order to get this information, you have to answer a few questions about your healthcare situation and your expected utilization of healthcare services. But this is a nice feature because I think one of the things that we need to move the marketplace towards is having people focus on the total cost of plans, not just the out-of-pocket premium expenses. We don't buy other products based on just the purchase price. I like to use the example of when we're shopping for cars. If you buy a car based solely on the purchase price, you're going to potentially be very surprised later on when you find out that this car has a poor repair record and you're spending a lot of time getting it fixed, a lot of out-of-pocket expenses. And it's the same with health insurance. So it matters what kind of plan we choose and the out-of-pocket spending. But for today's talk, what I want to focus on are the star ratings, because Covered California is trying to provide us with information about the quality of the plans. And you can see, I just selected these. I mean, there was no intention here. I just picked the first ones that came up when I put in some hypothetical data for this zip code. And what you see is the plans that came up, 2 Molina plans and HealthNet. Just so happens that these are, 2 one-star plans and a 2-star plan. So right off the bat, if I'm shopping, I'm saying, well, wait a minute, why is Covered California offering 1-star plans? This doesn't sound very good. And I can't do it in the slide, but if you're looking at this on the website, you can actually click on the quality or hover over the quality, and a little pop-up box comes up and explains that this is actually an aggregation of 10 different quality measures. And in this case, the quality measures are actually mostly patient experience and patient satisfaction. And what they've done is they've aggregated the performance across those 10 measures and basically provided a quartile ranking. And so what this really means is that the Molina plans here on these 10 scores performed in the lowest quartile. That doesn't necessarily mean that these are poor quality. The lowest quartile, depending on the distribution, could be 90%, right? I mean, it's conceivable that the distribution of scores here ranges between 90 and 95%. And when you do a quartile ranking, you have to be, if you're above 95, you're in the top quartile. And if you're at 90, you're in the lowest. So we really don't know that this means poor quality. It just is one way of trying to collapse 10 categories of information into something that's easily understandable. And I think that this is where we need to go. We need to provide consumers with information that's valuable and helps them make a choice. I don't know if this star system is there yet, but at least it's the direction that we need to go. But the other thing that I want to point out is, before I leave this slide, is that there's really, the only information we have about the network is the next line down, which says browse provider network per plan. So if I want to know how narrow Molina's network is compared to, say, HealthNet's network, there's really no way for me to easily do that. But I can click on the directory and sort through the directory and maybe get a sense of, well, HealthNet seems to have more or less doctors available in my area compared to Molina. And by the way, compared to the other plans that I'm not showing you here. So it's possible that I could do sort of a visual assessment, but there are no readily available data to show me in any measurable way what the difference is between these plans and other plans that are being offered. So we're not there yet. What kinds of insurance are sold on the exchanges? Well, remember that the ACA has standardized the policies that are sold on the exchanges. So all the policies have to have essential health benefits, limits on out-of-pocket spending, no cost coverage for preventive services, no annual or lifetime limits. The premiums can only be based on age, geographic area, and family size, and they have to be one of the 4 approved metal tiers. So this is just a summary of what the ACA requires. What are essential health benefits? These all plans have to offer services in each of these 10 categories. And the fact is that the plans don't get to choose what services they offer. The law says that each state must identify a benchmark plan. And that benchmark in that state will determine the precise services provided in each of these 10 categories. So in California, the benchmark plan is known as Kaiser Small 30 plan. It's a plan that was offered in the small group market. It has 30% co-payments for many services. But the level of benefits in ambulatory care, emergency services, hospitalization that are in that Kaiser plan are the benchmark for all plans offered by Covered California. So plans don't get to choose how many days of hospital care they're going to provide. They don't get to choose how much outpatient care they're going to provide. It's defined by that benchmark, and it applies to all plans. Now, this is a busy slide. It's hard to read in the room, and I'm sure it may be even more difficult for people on the webinar. But California went one step beyond the federal law. The California legislature said, we're going to standardize the 4 metal tiers in a way that makes comparison shopping even easier. So what California has done is standardize the tiers to say, for everyone who offers a bronze plan, the bronze plan will have a $5,000 deductible and co-payments that are defined according to this table. And I apologize that it's difficult to read. Squeezing all this information makes it a little difficult. But the fact is that every company that sells a bronze plan in the exchange and outside the exchange, for the plan that mirrors the plan that's being sold inside the exchange, has to comply with this co-payment and deductible structure. Now, what does that mean practically in California? Well, what it means is that, first of all, I can create a table like this that shows in the last open enrollment season all of the plans offered in covered California for a hypothetical couple. And this is a couple that, for HIPAA reasons, I can't disclose too much information about, but I happen to know this couple really well. Their age profile looks very familiar to me. So I can create a table that shows you every plan that was sold in the last open enrollment season and what the premium is for this couple. This is the entire set of plans available in Los Angeles, and specifically the part of Los Angeles below the San Gabriel Mountains. 5 years ago, or 3 years ago, before the exchange opened, it would be impossible for me to create such a table. There is no comparison, because before the ACA, there was no way to summarize all of the policies offered in the individual market in one table. Because the fact is that essentially every individual premium, every quote that you would get as an individual would be unique to you. There just was no way to create a comparable table. So what we've done with the ACA is we've standardized the benefit package. We have a benchmark. We've standardized the tiers. In California, we've gone one step further and standardized the tiers so that they have standard co-payments and deductibles, which is what allows me to do this table. For example, I could not produce a similar table in Arizona, because Arizona and no other state has standardized the co-payments and deductibles. So there are many, many, many bronze plans. The last count, last year when I looked at Arizona, there was something like 65 bronze plans being offered, all with very minimal differences, very, very minimal differences. Very hard to understand what the differences were, frankly. But in California, we've standardized. So what that leaves us with is what's different among these plans. I mean, you can see there's a little bit of price variation. But what's left? Well, what's left are the networks of doctors and hospitals that are part of these plans. That now has become the focus, and should be the focus, of consumers who are assessing what are the real differences among these plans. This slide just summarizes during the last open enrollment period what plans people actually bought in covered California. And you can see that almost 2/3 of individuals bought silver plans. And the reason for that is that there are additional subsidies that reduce the cost sharing requirements for anybody with less than 250% of the poverty level. So those additional subsidies make silver plans a very attractive alternative for a lot of people in the exchange. Bronze plans obviously are also very popular. Gold and platinum not so much, because higher premiums, lower out-of-pocket spending, but the premiums on a monthly basis are higher. So a much smaller percentage of the market. But I also wanted to focus on the enrollment by carrier, because California is a concentrated market. There are 4 big insurers in the state, and not surprising, there are 4 big insurers in the exchange. And when you look at the care provided by those, it's a mix of HMO and PPO services. It's not really shown here on the slide, but we know that Kaiser is an HMO. Anthem offers both HMO and PPO products. Blue Shield offers essentially PPO products. And HealthNet is also a blend, but primarily HMO products. And then you have smaller insurers, many of which are also HMOs. So it leads me to sort of the concern that's been raised, and as Dr. Parat mentioned in her introductory comments, it is one of the questions, one of the most frequent questions that we get here at the center from reporters. Are networks, first of all, are narrow networks a problem? And the subsidiary question or related question is this because of the ACA? Isn't it the ACA that's caused narrow networks? And the simple answer is no, not really. Narrow networks are not new. They're not new at all, especially in California. HMOs have been around for decades. HMOs, by definition, are narrow networks. And remember, we're also talking about the individual insurance market here that's affected by the ACA. The large group market, which is largely unaffected by the ACA, not entirely, but largely unaffected. We don't have good data on narrow networks, but a recent survey suggests that about 17% of large employers this year are offering narrow networks to their employees as a potential cost-saving measure. So what I tell reporters, and part of my message today, is that the ACA didn't create narrow networks, but it may have accelerated the growth of them. But what it's also done is it's increased the transparency, particularly in the individual insurance market. So now, just like I was saying with the slide, the previous slide with all of the prices for all the plans, it was impossible to produce that slide in 2013 before the ACA went into effect. We also just don't know how narrow networks were prior to the ACA because we weren't tracking it in any systematic fashion. So the fact is that the narrow networks probably are more prevalent today than they were 3 years ago. And they're being used as a mechanism to keep premiums affordable in exchanges all over the country, not just in California. So that brings us really to I think what is the heart of the issue here, which is, are narrow networks a problem? I would say by definition, the fact that the term itself implies that there is a problem. There's almost a guilt by association. Calling a network narrow implies that it's just not as good as a regular network. Somehow we've squeezed things a little bit too much. The fact is, there may be a problem, but we don't really know. And I think to foreshadow where I'm going to go with the remainder of my comments today before I open it up to Q&A, is that the evidence seems to suggest that they are not a problem. The evidence that we have, but the evidence is not overwhelming yet. And like a good researcher, I'm going to suggest that we need to do more work in this area before we can really conclude that these networks are not causing problems in the marketplace. So let me just step back from it and say that narrow networks really should not be a problem unless they either limit access to medically necessary care provided in a timely fashion, or if they limit access to quality care in general. In other words, a narrow network that consisted solely of low-quality providers could be a very serious problem. But we don't know whether these networks have those characteristics or not. As Californians, we know Kaiser is a narrow network by definition. Everybody who is a Kaiser member knows going in when you join Kaiser, you are joining a narrow network. You cannot go to any hospital. You cannot go to any doctor You go to their doctors in their facilities. If you have an emergency, you can be treated anywhere. But you are joining a system, and it is a narrow system. But the fact is that this narrow network that has been in California for decades currently has the largest market share overall in the state. It's the second largest in the graph that I showed you in covered California, but overall it has the largest market share. I think the most recent data indicate almost 7 million people statewide enrolled in Kaiser. And they consistently perform well on quality measures. On all of the measures that we have, or almost all of the measures, Kaiser consistently performs well. I didn't show you the covered California, but Kaiser plans tend to be the 4-star plans. So we have a lot of experience here in California suggesting that a narrow network does not necessarily have to be problematic and it can function. But we also know that Kaiser is a unique system because it is a closed system. And what we're really, I think, concerned about is whether in an open system where doctors and hospitals don't belong just to one plan, but will take patients from many different plans, whether or not there are quality or access problems associated with narrow networks when you have an open system of providers. And there is at least one study that was published earlier this year by Dan Polsky and his colleague at the University of Pennsylvania that showed that California ranked 4th in overall network narrowness. And what they did in their study was they looked at the percentage of physicians in each market area in each state who were part of the provider networks and the plans being offered in the exchange, and found that 75% of the plans offered in covered California included 25% or less of the available physicians. So their study, based on what I would consider to be a very crude measure of network narrowness, suggests that, first of all, California is one of the states with the most narrow networks, and that if there are problems, it would likely to be occurring here rather than in some other states. I'll come back at the end with some other studies that provide different evidence regarding how narrow networks are working in California. So let me just review currently what the standards are for network adequacy in California. I'm going to come back to the issue of narrowness versus adequacy in just a minute. But currently, the state of California, and specifically in covered California, the qualified health plans that are offered are all subject to federal and state regulation. It's primarily state regulation. One of the problems that we have in California, though, is that we have 2 regulatory agencies that are responsible for regulating health insurance. And this is a historical, I won't call it an anomaly, but a historical sort of evolution of the market and the growth of managed care in California. During the 1970s, the view that the Department of Health Insurance was not necessarily adequately regulating managed care plans that were growing very rapidly. So in California, we created a separate regulatory authority, the Department of Managed Healthcare. The problem is with regard to network adequacy. So both of these agencies regulate plans, and essentially before they can be offered to residents of the state, they have to meet these network adequacy requirements. The problem is that the agencies have inconsistent requirements. And that is one of the problems with having 2 different agencies regulating health insurance in the state. Both agencies have standards that deal with the numbers and types of providers, geographic access to care to make sure that you have timely access within the area where you live, timely access with regard to getting appointments and getting in to see doctors, provisions for out-of-network services, mostly for emergency care, And then options for medically necessary treatments that might not be provided within the network. So both agencies have standards within these, although the standards vary. They're not consistent. And the other point that I want to emphasize is that standard setting, although it's important, is, I think, just one piece of the puzzle. Because in fact, when government agencies set standards, which are important, if standard setting alone was sufficient to guarantee that plans were providing adequate access and adequate quality, we could just set the standards and then walk away and say, well, we're done. In fact, I could finish my talk and I could open it up for Q&A right now. The fact is that standard setting alone is not sufficient to guarantee that networks are adequate. And I would suggest that we also need to, on a regular basis, monitor how plans are performing with regard to these standards and other standards or other requirements that are not necessarily in the existing standards. So let me just show you quickly a couple slides from Kaiser Family Foundation that is doing surveying Californians who were previously uninsured. This is their cohort study that started in 2013, and they've been following a cohort of individuals who are uninsured to see what happens to them, what their experience is. And a couple of the slides in their recent report are relevant to today's discussion on narrow networks. What I really want to focus on here are the parts of the bars that I'm not exactly sure how to describe the color, but it's sort of the light orange portion that says that this was the only place available. So in response to the question, why did you choose this particular usual source of care, that sort of light orange portion of each bar shows individuals who said this was the only place I could get care. So for the uninsured, about 14% responded that way. For Medi-Cal, about 20%. Those in covered California, 10%. And those who had other private insurance prior to the ACA showed 6%, only 6% answered. So I would suggest that this is possibly one indicator of access problems. If you only have one place to get care and have selected a usual provider because you don't feel that you really had choice, that this may be in one possible indication of network inadequacy. And I think it is a cause for concern that such a high percentage of Medi-Cal beneficiaries are reporting that, although frankly I'm not surprised that this is more of a problem in the Medi-Cal population. Another measure is ease of travel to your usual source of care. And here the numbers are a little bit more encouraging. You see an extremely high percentage of people reporting that they have timely access. And in covered California, it's essentially the same as other private insurance. Again, Medi-Cal is low, and it's about the same as the uninsured. Again, I think that this is potentially an indication of network inadequacy as opposed to adequacy. But this number is reassuring, certainly for covered California. Problems getting medical appointments, I think, is another dimension of possible network adequacy or inadequacy. And you can see a provider, first question, a provider would not accept you as a new patient. Very high percentage of covered California individuals reported this in the Kaiser survey, 18%, much higher than the other categories. And anecdotally, this is the kind of evidence that's being reported to us. We hear that people are being turned down, that their providers saying, I don't accept covered California, even though they may be listed as being in the provider directory. And that's why the individual selected that doctor as a primary care doctor. A high percentage of covered California members reporting that their provider did not accept them as a new patient. And then with regard to waiting longer than reasonable for an appointment, Again, Medi-Cal beneficiaries reporting a very high percentage, 1 in 5 reporting that they had problems, but a high percentage of both covered California and privately insured patients reporting problems in this area. And I think these comparisons are important because these provide the benchmarks. If we didn't have the other privately insured in here, we might say these are all problems. And yet the fact is that well-insured individuals with private insurance from large employers like UCLA have problems accessing healthcare. This is not a problem that's unique to Covered California or to the Medi-Cal program. But what we want is comparative data so that we can gauge, are there differential problems across these different insurance categories. So I mentioned a few minutes ago that network adequacy versus narrowness, I think, is an important distinction. And you might think about it as just like the flip side of the same concept, but I think that really what we want to do is we want to focus on network adequacy. We want, I think, as a society, as consumers of healthcare, reassurance and confidence that the networks that we have are adequate. Narrowness per se, I don't know what to do with the information. I'm in a narrow network. I'm in an HMO. The fact that I'm in a narrow network in and of itself doesn't bother me. What I'm concerned about is, within that narrow network, can I get timely access to the care that I need? Can I get referred to a specialist? If I need urgent or emergency care, can I get it? That's what I'm concerned about. The fact that I can't go to any doctor or any hospital in the state in and of itself does not strike me as a problem, particularly if I have a guarantee that I can get that coverage in an emergency situation, which essentially all plans guarantee, and I'll come back to that. So I think that rather than focusing on narrowness, what we really should be doing is thinking about network adequacy. And I think that adequacy has two dimensions. They're separate, but both contribute to the notion of adequacy. One is the obvious one is access, and that includes both potential access in terms of number of providers, distance to closest provider. But I don't think that potential access is enough. Just saying that 65% of the physicians in my market are in the network is not really, I think, the best measure. It's a potential indication, and it's what Polsky and Weiner produced in their report earlier this year, looking at national data. But it's just one piece of the picture. I think really we also want to look at actual or realized access, and that is, how difficult, like some of the data that I was just showing you from Kaiser's survey. That's what is, I think, important in terms of assessing adequacy, and that's not necessarily what the regulatory agencies are currently doing. But I think Covered California as a marketplace has the potential to provide this kind of information to consumers in addition to the regulatory requirements that plans have to go through. But I think that adequacy also requires some quality measurement as well. And I think that the two important dimensions that have been recognized are patient experience and satisfaction, as well as clinical outcomes. And I think clinical outcomes matter. And I'll show you some, I'll talk about a couple studies that have been done in California to measure that. So how should we measure adequacy of networks? I think at a minimum, we need to measure the adequacy for each of the major components of care that we're likely to experience in the healthcare system. And this is important both to current members as well as potential members thinking about switching into these plans or buying these plans. And I think the requirements are, we need to look separately at primary care, specialty care, which includes mental health and substance abuse services, inpatient hospital care, and emergency services. So let me talk just a few minutes about each of these. I think for the primary care measures, we need for every rating region some annual measure of the kinds of indicators here. And this isn't intended to be an exhaustive list. This is sort of my first take, as well as what I've gleaned from the literature about what's being measured, what seems to be important. But I feel like this kind of information has value to people in selecting health plans. These are the things that I would like to know about my plan, and how does my plan compare with some other plan that might be available to me. And by the way, I don't think that this should just be available on Covered California. I'd like UCLA and the UC system to provide similar data to me on the plans that are available. And I think that most people who have a choice of their place of employment would like to know this information as well for the options that are available to them. And I'm happy to talk about specific items and come back to this, but I don't want to go into detail right now. I think for specialty care, it's similar to primary care providers with a few differences. Some of the issues aren't as relevant, but a number of these are exactly the same as I showed on the previous slide. I mentioned emergency services, and the fact is that I think with regard to network adequacy that this actually should not be an issue for the following reason. At least in California, by law, HMOs have to provide emergency services to the members without any cost sharing. And I actually just discovered this recently when I was preparing this talk and responding to another request. About 4 or 5 years ago, California passed a law requiring HMOs to hold their members harmless financially if they receive emergency care out of network. That law does not apply to plans regulated by the Department of Insurance, and although those plans are required to provide coverage, it is still possible if you receive emergency care in a PPO, or what is known as an exclusive provider organization, which is kind of a hybrid between an HMO and a PPO. If you receive emergency services, you can still get a surprise bill, particularly from emergency room physicians, including anesthesiologists. So the protections that are in place for HMO members don't fully apply to people, and this is being addressed by by legislation that was introduced into the legislature to eliminate surprise bills. But my understanding is that the surprise bill the surprise billing bill still has not passed the legislature. So anyway, I think that in general, in terms of network adequacy, I think in general we have a lot of protections here, with the exception being the financial protections that are not in place, in my opinion, fully for PPO patients and members. Finally, for inpatient hospital, I think that just obviously the percentage of hospitals in the network is an important measure. But as I said earlier, I also think that some measure of clinical outcomes should be incorporated. We have a lot of quality measures for hospital care, much more so than on the outpatient side. And Medicare has been collecting that information. Medicare has its star rating system, which is based on the responses. Now, this is mostly patient experience and satisfaction, but it's based on all patients in the hospital, not just Medicare beneficiaries. So Medicare has been providing this information on its website through what's called the Hospital Compare website. And I think those star ratings, it would be useful to include those as a measure of network adequacy. What's the average Medicare star rating of the hospitals in my plan's network? The next, just two other points that I want to make with regard to hospital measures. I think, and this is where, I think concern about narrowness of networks and network adequacy gets really controversial and sort of hits home, particularly here in Los Angeles County. I think the fact is that the vast majority of hospital care can be provided adequately at any hospital. If it wasn't, we shouldn't be licensing these facilities. If I need an appendectomy, I shouldn't have to worry about what hospital I'm getting my appendectomy, especially, if I don't have a choice and it's an emergency. But what about the rare conditions? And I think that the reason that many of us have sort of this fundamental gut level concern about network narrowness is, what if something really bad happens to me and my network does not include the major teaching hospitals in my city, i.e. UCLA? What am I going to do? Now, if you go back to the slide that talks about the requirement by the regulatory agencies that there is a mechanism for anybody to get out-of-network care if the needed care is not available in network, in a sense provides blanket protection. But I'm looking in the audience, and those on the webinar can't see everybody in the audience, but their heads shaking, well, no. And I think that's the concern. If I am faced with a serious illness and particularly a rare illness, how confident am I that I'm going to be able, using the protections that are in state law, to get the care that I need? And if the care I need is a referral to UCLA or to Cedars, am I going to be able to work the system and convince my insurance plan that the doctor I need to see is there and not in the network? And by the way, I'm dealing with a serious illness that could be life-threatening. So I think that this is why we have this concern. There are these legal protections and there are standards in terms of evaluating plans for providing quote-unquote protection. In my opinion, it's not enough. I think that this is an area where I understand that the market dynamics may be why teaching hospitals are not included in networks. But relying on waiting for someone to have a serious illness and then having to prove or go through an appeals process to get approval, meanwhile knowing that there's a probability that that appeal will be unsuccessful. Put yourself in that situation, and unfortunately I think you may not have to imagine it. Some of you may have been in this situation. And it's not what we would want for anybody. We would not wish this on anybody, to deny access to the best care available when you need it. And I'm not talking about the appendectomy or the normal delivery. I'm talking about the rare brain cancer. So I think this is an issue that we haven't resolved, and I'm happy to talk about a little bit more during the Q&A. But let me just wrap up here so that I don't use up the whole hour talking. With a few final thoughts. So I alluded to the fact that there have been a few studies of network adequacy in California. One was by Spurlock for the California Healthcare Foundation. And his work showed, and this was just published within the last month, that network narrowness was not associated with hospital quality in California, which he concluded was reassuring. And his conclusion is that consumers can focus on access in California rather than quality, at least when it comes to hospital care for the products being sold in covered California, because there was no association between narrowness and hospital quality. And so that's one study that was done. Another published a little bit earlier this year in Health Affairs showed that in 2014, covered California plans had narrower hospital networks than commercial plans. But the quality was equal to, or according to one of the three measures that they used, actually better and statistically significantly better in the hospitals that were part of covered California networks, which again is reassuring. Now this is just, these are the hospitals. So it says nothing about specialty care, it says nothing about primary care networks, adequacy of doctors in the networks, timeliness of care. None of that's being measured here. This is just the one thing where we can actually do some research because we've got quality tons of quality indicators for hospitals, not only in California but across the country. So the research to date seems to be pointing in the right direction, that despite the narrowness of networks in California, that at least with regard to hospitals, it doesn't seem to be a problem. So I wouldn't be a good researcher if I didn't say that more research if I went without saying that more research is needed. Obviously, more research is needed. But what I think we really need in California and across the country is, and I think it's reasonable to get here by the end of the decade, is we need to do research that translates findings into meaningful measures that consumers can use. Again, I pointed to the star rating system of Covered California, and not to be critical, but it's not enough. We need more information. And as much as I would like to see everything simplified into a star rating system, because as I've told students for 25 years here at UCLA, I think that our goal is to get to a consumer report sort of system where people can have confidence that those 5 stars capture all of the important dimensions. The problem in healthcare is that with cars, there are probably 6 or 7 important dimensions, and so you can collapse that into a star system. In healthcare, there are probably 30 or 50 dimensions, some of which are interrelated and measuring the same thing, some of which are distinct, and collapsing that into a 5-star system is very difficult. So maybe before we force things into a star system and put up plans that have 1 star, in suggesting to me that they're poor quality, maybe what we need to do is to unpack these measures and just provide lots of raw data to people and say 61% of members in this plan were happy versus 83% in that plan, and let individuals decide if that's a meaningful difference or not, rather than trying to force this into a 4 or a 5-star system. But the final point that I'll close on is that I think additional legislation may be necessary as well. And as just one indication, in this past session, SB 137 was introduced, and I think the governor signed about a month ago, or actually earlier this month, about 3 weeks ago, to require plans to provide more timely and accurate information on their provider networks, including weekly updates, not monthly or annual updates, weekly updates to the provider directories, so that when you are shopping for a plan, you have really current information. So I will stop there. Hopefully I've stimulated some interesting questions on your part, and let me open up the floor for questions now. Thanks. Yes?
You mentioned the percentage differential for what I assume is an aggregate number of that quantifies the narrow network. Is there a percentage for specialists?
I haven't seen it, so so I'll repeat the question. I provided data earlier. I think you're referring to the Polsky study that showed that 75% of California plans offered in Covered California had fewer than 25% of the doctors in that area as part of their plan, and they use that threshold to define narrowness. In their study, they didn't break it out into specialists, at least not that I'm aware of in the brief that was published. Maybe they are working on that, and that information will be forthcoming later. But
so we're going to switch to the web questions.
Oh, okay.
Audience questions.
All right,
so
good.
I'll ask a question from the web. So one of our listeners says that in I believe it's the Blue Shield, Blue Cross Blue Shield in Texas has announced that it will no longer offer PPO plans in the federal marketplace for 2016, which means that essentially the market is further narrowing in a different way. And whether you think that that is possibly going to happen in California or is happening. So we could repeat the question.
yeah, so the question, one of the questions from the web is in Texas, the they've announced that they will not be offering any PPO plans. Is that for the current open enrollment season?
For 2016.
For 2016, so in the upcoming open enrollment season, it will only be HMO
Only
products.
Blue Cross and Blue Shield have announced this. So
Oh, only Blue Cross and Blue Shield. Oh, I'm sorry. So they're not going to offer a PPO plan.
yes.
And I assume that they are probably a big player in the market, but certainly not the only insurer. It's a little difficult to forecast what insurers will continue to do in the marketplace, and specifically in the ACA marketplace. I haven't seen good data on the national breakdown between PPO and HMO plans. I think that HMOs provide the mechanism for keeping premiums affordable because they do have a narrower network. But I also think that the marketplace, that there are enough people in the marketplace who want more choice, willing to pay slightly higher premiums. And if I don't know if I can go back to the slide for 2015. So this is from last year, and these were the premiums that were in place for this entire calendar year. But this is from the last open enrollment, and you can see that the HMO products certainly were the cheapest. That's the cheapest ones were mostly Health Net HMO, but in general, HMO products were less expensive. But PPO products, I think, will continue to be offered in the market because there's demand for them, and people are willing to pay slightly higher premiums.
Questions here? I can pose a second question from the web, which, oh, go ahead.
Thank you, Dr. Clinton, first of all.
Yes.
Are there any comments related to rural geographies? Because that to me is very interesting that you might have actually a pretty broad network in a rural area, but the quality would be very different with the other comments.
Yeah, so I haven't seen any good work on, the question is regarding rural areas and whether narrow networks, sort of that urban-rural difference in narrowness. I think that the market dynamics are quite different. So in a rural area, some of these measures are going to look different, and they might look worse, just given the supply of doctors and hospitals. For example, in some rural counties where you have one community hospital, average travel distance could be exceed 30 minutes for a very high percentage of that area's residents. That's not because of the narrow network per se, that's just because of rural living, and you would assume that people understand that when they make the choices that they make about where they're going to live. But I think that's why we need to have these by rating region. You can't have statewide standards, for example, because in an urban area, actually, I think the narrower the network, the less concern we may have because there are lots of providers. I forget how many hospitals there are within a 5-mile radius of where we're standing, but there are quite a few. So if only 20% of the hospitals within the 5-mile radius of here are part of my network, that may be more than enough, because that could be 4 hospitals. But 20% sounds like a low percentage. But how many hospitals do I need to go to? What I really need, and I think what some of the measures look at, is what is your travel time to the place closest to where you live or work. So really what that means for me is UCLA part of my network? Or if it's not, is there another hospital close by? I don't need to have every hospital in my network, but I need to have one that's close to here, because this is where I spend most of my time. So I don't know if that answers your question or not, but I think with regard to rural areas, I think we would see very different standards and have different expectations. And I'm not exactly sure what those measures would look like, but my feeling is that network adequacy, we're going to judge it differently based on travel times and the availability of providers. The fact that there aren't numerous hospitals in every county. I think it's a persistent problem of living in a rural area that there aren't enough doctors. Doctors, like the general population, want to live in urban areas. I think there's some data that suggests that doctors concentrate maybe a little bit more in urban areas than the general population.
So the next question from the web is a counterpoint to the narrowness. Some of the plans that actually participated had to expand their networks in certain areas that may not have been previously. So that's the main point.
Oh, yeah.
What about the expansion that might have been experienced?
Right, so the question, it's more of a comment maybe than a question, but that some insurers, in order to participate in Covered California, had to expand into market areas in order to meet the network adequacy. So I think in that case, this is where regulatory standard setting is serving the goal that we want it to serve, which is, look, if you're going to go into this market, then you need to demonstrate that you have an adequate capacity in an area where you haven't been. And that's exactly what we want regulations to do. I think the point that I was emphasizing earlier is that relying on the regulatory standards alone is sort of, it doesn't recognize that markets are dynamic and that a plan may meet those standards at the time that they apply for approval to offer a product, but that performance over time may be different from demonstrating the capacity to provide care. So capacity versus actual delivery of on-time care may be, those two may be out of sync. And so as a result, we need to monitor, and I think the monitoring the actual data on performance matters as much as setting the right standards.
Okay. I can ask another question. There is a comment about the fact that providers can end their contracts at any point during the year, but then the patients are left without a provider that might have been okay and their choice. So essentially, what about the fact that there's this discrepancy between providers that could leave at any time?
So I think that one of the protections, as I understand it, in that situation is that continuity of care provisions, that you can, if your provider leaves your plan or your network, that you can continue to receive, if you are under treatment for a condition, you can continue to see that provider under the arrangements that the insurance company had with that provider until your treatment is complete. And I don't know if that applies to both segments of the market or not, but I know that there are protections in place, at least to guarantee that while you're actively being treated for a condition that you can complete with that provider. But I think this is one of the reasons why the legislation, like the Hernandez bill, SB 137, was necessary as well, because provider directories that are updated once a year and that are inaccurate even when they're updated don't serve anybody well. And what we've done is we've created a marketplace where one of the key differences between these plans is the provider network. So if we don't have good information, we don't hold plans to a high standard, then we're doing a disservice to everybody in the marketplace.
And then
What we can have a question.
I just have a question about that Hernandez bill and this provider directory
Yeah.
updating. Because access issues are related to those directories not being updated or being inaccurate. And my understanding from my insurance provider is that it's up to the provider to inform the insurance company. And so the bill suggests that really the insurance company is the one that should be updating with, but I understand that it's on the provider side. And so maybe there's maybe that bill doesn't really address the problem. And if I'm incorrect in that understanding, then what would be the consequence if HealthNet doesn't weekly update their provider dental list when I'm continuously trying to find out through what access? So would there be fines, and would they be substantial enough to make that administrative effort? Because they're pretty bad on that.
So the question deals with the SB 137 and the requirement now that plans in California update their provider directories on a weekly basis. And is there a penalty associated or any sort of fine, or what's the passing a law is one thing, how do we actually guarantee compliance? And that is going to be a challenge. I'm not familiar with all of the aspects of the law, so I don't know if there are provisions for penalties, for example. So I don't know what the compliance requirements are in the law. I'm sorry to say that I don't know the details, but I don't think that there are penalties in there, and as a result, I think that compliance may be an issue, and I think that that's one of the reasons that I emphasized a couple times during my talk that having data on actual experience that members have is really important in judging network adequacy and factoring. I think it's important for the insurance regulators to take into account. So I'm arguing that I think that DMHC and CDI should look as well at what plans are actually doing and how they're performing, as opposed to what their capacity for delivering adequate care. And this would be one of those cases.
But is it actually their responsibility, or is it the responsibility of the provider to inform the insurance company whether they're still in network?
My understanding is that the responsibility is on the networks. I'm sorry, on the plans. On the plans.
Can I offer a comment from an international perspective?
Sure.
You may be aware that the National Health Service in England has a patient choice website where, in fact, they break down a lot of the quality indicator components, giving the information that you are emphasizing. So rather than a kind of overall summary star, you can actually, as a patient, go into this patient choice website and find out how many hospitals are in that area of those, how many deaths are associated with certain types of surgeries or whatnot. So there's a level of disaggregation that might be of interest when we're comparing to kind of re-emphasize your point.
Yeah, and Medicare is providing, I think Medicare is driving a lot of these quality concerns. Of course, they're not the only ones. We've been working for decades here in the U.S. By the way, the follow-up comment was with regard to the UK and the fact that there is a website that allows comparison of hospitals on a number of dimensions rather than a collapsed quality score.
But GPs as well?
And GPs as well.
And the whole range.
So there have been tremendous efforts in the United States for, dating back 3 decades to begin to not only define quality measures, but make quality measures more readily available, more readily understandable. But we've been working at this a long time, and we're still trying to figure out how to do it in a way that is useful in decision making, so that we're not just writing good scientific papers and doing good science in terms of measuring the individual dimensions and making sure that we do the appropriate factor analysis, for example, to separate what the dimensions are, but to actually put this in the hands of consumers that in a way that it facilitates decision making. And that's where I think that we still have a lot of progress to make. So we're doing good science, but the translational part is where we're still lagging.
Okay. Thank you.
Thank you. Thank you very much. Thanks to those of you in the room and to those viewing on the webinar. Do you have a final?
Okay, thank you everyone. That's the seminar webinar for today. Look forward to having you for our next one. Have a good day.
Thanks.